Alo Mingla, Jala, General, the General is a Colonsia Siama Idib, General Medicine, Senate Jolabo, now good GI Maro, Dineso, GI Yauda, and then say, General Sia Imia Pijare, my Totanans way, Totini, Sia they saw, Sia Ujolarum to no, Sia Udemia, no, Alo, Jedu Temare, Teo Alo, now, Zifam CEO, this kind of coming from the Australia, Sydney. And also the Zifam team did this Lotte Hotel for your this CME program. So this topic is the in foundation that topic is noble acid blocker and GERD. But in really I would like to talk about the more on the GERD. So I've changed the topic to the management of GERD. So GERD is the recurrent retrograde flow of the gastric contents into the esophagus and into sometimes into the oropharynx. So there's three main types of GERD. One is non-erosive, and second one is erosive esophagitis, and third one is Barrett esophagus, and later any in the adenocarcinoma esophagus. So this is the distribution of GERD prevalence. So you can see the high prevalence in the North America and the some Europe country, and lowest prevalent in I think around the China. So anatomical structures, so physiological mechanism protect against GERD is 1, esophageal motility, 2, saliva production, and 3, the esophageal epithelium protections. So usually diagnosis of GERD is symptom-based. So symptoms, this heartburn, regurgitation, and sometimes chest pain or sometimes extraesophageal symptoms. So, which is confirmed by upper GI endoscopy or sometimes in special cases like refractory GERD or for the research purpose, we did M2, which is the multi-channel intraluminal impedance pH study. So diagnosis is usually symptom-based, classical symptom, heartburn, regurgitation, chest pain. So these symptoms have high sensitivity and specificity for the diagnosis of GERD. Atypical symptoms like chronic cough, hoarseness of voice, sensation of lump in the throat. Usually this the common presentation of this GERD patient, the global sensations in the throat. So there is the symptom questionnaire for the diagnosis of GERD. I don't go into detail. And this is the OGD, gastroscopy finding of GERD. Usually we use the LA classification A to D. And for endoscopy, we can detect the chronic complication of acid reflux in the esophagus, like esophageal strictures, the Barrett esophagus. Confirmatory test for GERD is the 24-hour pH impedance, so which we can detect the retrograde bolus movement, number of reflex events, total reflex time, association between symptoms and reflex episodes, whether it's reflex material acid, weakly acid, or alkalines. This pH test is the most sensitive and specific investigation and diagnosis of GERD. So, 24-hour pH impedance in the line consensus in the 2018. There is what we call is the AED, is the acid exposure times for 24 hours. It's less than 4%, it is normal. Between 4 to 6%, it is recommended for other measures to prove GERD. It's more than 6%, it is the confirmation of GERD. So in the right-hand side, the reflex episodes is more than 80, it is abnormal. In the less than 40, it is normal. So this is the 24-hour pH impedance. So in row 4 criteria, a patient present with heartburn, we do the endoscopy and biopsy, but GERD is not proven. So we off the PPI for 2 to 4 weeks, and did the pH monitoring and impedance study. When it is normal acid exposure and negative symptom reflex association, this is a functional heartburn. Normal acid exposure, positive symptoms, reflex association, this is the reflex hypersensitivity. Abnormal acid exposure and positive or negative symptom association, this is the non-erosive reflux disease. So another test is manometry. We usually don't do manometry, but in case like to exclude the eclampsia, hernia, abnormal LES pressure, esophageal dysmotility, So in special case, we did this esophageal manometry. So the consensus in diagnosis of GERD is the line consensus, Porto consensus, British Society of Gastroenterology guideline, and American College of Gastroenterology guideline. So the three main components is GERD. We can diagnose GERD by pH impedance study, AED, SH product more than 6%. This is the confirmation of GERD. So in conclusive cases, the AED between 4 to 6%, and not GERD is a AED less than 4%. So in lower part, we can differentiate between functional heartburn and the reflex hypersensitivity by this pH impedance study. So all the investigation required for diagnosis of GERD. So not all are required for diagnosis of GERD, and we can take OGD in case like in the presence of alarm symptoms like dysphagia, orinophagia, anemia, bleeding, and weight loss. And also the person who has the high risk for virus like chronic and frequent symptoms, age more than 50, Caucasian race, and central obesity. Treatment aim is to relieve the symptoms, heal any damage to the esophagus, and to prevent and complications. So 4 main components: 1, lifestyle modification; 2, pharmacological treatment; 3, endoscopic treatment; and lastly, surgery. So regarding the lifestyle modification, the main component of this management is the weight reduction in case of obesity. And also important is meal timing and eating behaviors. Lifestyle modifications also avoid the triggers, dietary triggers, and also individualize the food avoidance, like avoidance of the spicy, acidic foods, caffeine, chocolate, fatty meat, peppermint, and carbonated beverages. And also we ask the patient to make the dietary diary, like the My Reflex symptom diary. So to know the associations of reflex with the symptoms. So also the alcohol is each person drinks alcohol more than 3 to 5 times a week. There is a double the chance of developing the GERD, and also cessation of smoking is also important because smoking reduces the lower esophageal sphincter pressures. Another one, this is the bed elevation and sleeping position. So sleeping position, they recommended to lie on the left side. Second one is pharmacological treatment. So there are proton pump inhibitor, histamine, H2 receptor blocker, PCAB, mucosal-protective agents, and prokinetics. So proton pump inhibitor mechanism already explained by Professor Myint Aung. And proton pump PPI, when we give the PPI, there's a sustained increase in the intragastric pH, which reduces the stromatoscopic-mediated inhibitions of gastric release, and which lead to the hypergastrinemia. This lead to the gastric mucosal proliferations, including the proliferations of the endochromatin-like cells. So this ABCD is the endoscopic finding who took PPI in the prolonged times. So PPI is the cornerstone of GERD treatments. Despite these physiological changes, these PPI can cause strong acid suppressions and proven clinical efficacy. So PPI heals 80 to 90% of erosive esophagitis within 8 weeks and provide significant symptoms relief in the majority of GERD patients. So this is that's already said, this PPI has some rapid metabolizer, slow metabolizer, according to this cytochrome 2C90 enzyme status. So we can safely use rabiprazole, especially in these cytochrome C2C19 metabolizer. We can liberally use rabiprazole other than the omeprazole and the pantoprazole. So timing and dosing, this is taken 30 to 60 minutes before breakfast when the proton pump activation highest, once daily control symptom in the most patients who refractory or not dominant symptom, they may benefit from the PD doses. So duration, so in uncomplicated cases, we usually give 4 to 8 weeks, and the symptoms are relieved we usually follow step-down approach, like dose reduction from BD to OD, transition to the on-demand therapy, or intermittent therapy, or switching to the H2 receptor blocker. So in case of LA grade C or D esophageal peptide switchers, viral esophagus who got rapid relapse after PPI stoppage. So in this case, we recommend long-term maintenance therapy or PPI. Another one is the H2 receptor antagonist. The standard dose of these drugs, approximately 40% of erosive esophagitis over the 4 to 12 weeks. But the main disadvantage is H2 receptor blocker can cause tachyphylaxis in the short duration. So the combined with PPI, BD, and H2 receptor blocker, the nodanic acid breakthrough, we can prevent nodanic acid breakthrough when H2 receptor blocker is combined with the PPI. Then another one is the latest medicine is PCAP, the potassium channel acid blocker. So completely blocking the potassium channel and binding to the hydropotassium ATPase, so preventing the gastroesophageal in the reversible manner. So these are already explained by Professor Uday Myint, so I cannot go into detail. This PCAP is the systematic reviews and randomized trial show vonoprazan 20 milligram a day in overall is non-inferior to conventional PPI, while conferring a clear healing advantage in the patients with severe GERD like LA grade C and D. So also, compared to PPI, PCAP has superior efficacy and faster therapeutic effect in the initial and maintenance therapy of GERD, particularly severe GERD. While PCAP may have alternative treatment options in non-erosive reflux disease and PPI-resistant GERD, findings are inconclusive in the patient with nighttime heartburn. So this is the endoscopic finding may be seen in the patient who took PCAP. Another one is mucosal protective agents, two main groups, sucralose and alginase. So to save the time, I will skip these. Another one is the prokinetics. Prokinetics is the approximately 40% of patients with functional dyspepsia have the impaired gastric accommodations, so causing the lower esophageal sphincter realization resulting in GERD and functional dyspepsia overlaps. So these kind of patients are very difficult to treat, and meta-analysis in 2020 show global prevalence in FT-GERD overlaps is 7.4%. So also the several meta-analysis show prokinetic plus PPI is better than PPI monotherapy, which shows significant improvement in symptom response, greater symptom relief, and improvement in quality of life. What you can do if GERD symptoms are refractory is to confirm diagnosis, to optimize medications, to consider additional or alternative treatment plan, and to exclude the differential diagnosis. So I will skip this slide. So adjunctive treatment for GERD like the GABA, baclofen, so we can be applying to the junction or the esophagogastric junction. So baclofen reduce the frequencies of transient lower esophageal sphincter relaxations. So another adjunctive treatment for GERD is diaphragmatic breathing, which is the breathing exercise. I think we can be done by the physiotherapist. So another one for supportive treatment for the GERD is esophageal directed hypnotherapy. Next is the neuromodulation. So neuromodulation is principally lower esophageal sphincter electrical stimulation using an implantable electrical stimulator. Also, transcutaneous electrical acute stimulations, and also manual acupunctures. So after the acute puncture, there is a significant increase in the length of lower esophageal sphincter and the length of intra-abdominal lower esophageal sphincter, mean basal pressure of lower esophageal sphincter, and decrease in the numbers of fragmented contractions and ineffective contractions. Another one is the endoscopic treatment. So patients with GERD who are candidates for endoscopy therapy is typical GERD symptoms, mild to moderate erosive esophagitis, early grade A or B, or non-erosive reflux disease, higher hernia less than 3 centimeters, with complete or partial response to PPI treatment, who are not suitable for or not willing to undergo anti-reflux surgeries, who are not willing to take long-term medical treatment. So these are candidates for endoscopic therapy. Number one is TIF, the transoral incisionless fundoplication. This needs special endoscope and special device. Another endoscopic treatment, endoscopic radio frequency ablations, or these EG junction, we call it structural procedures. Another one is the GERD-X. It's just along the full thickness plications or this gastric cardia and fundus, which is known as the endoscopic full thickness fundoplication technique. Another one is the MUSC, Muse Medicus Ultrasonic Surgical Endostaplas. Other endoscopic anti-reflux surgery, one AMS is the anti-reflux mucosectomy and anti-reflux mucosal ablations. Next one is the par-oral endoscopic cardiac constriction, BECC. The last one is the surgery. So the anti-reflux surgery, or known laparoscopy or open fundoplication, magnetic sphincter accommodations. So take-home message is this left-hand side is for the management of GERD. So the main cause of the GERD is the ineffective esophagogastric junctions, earlier sphincter, and also the combinations or presence of hide hernia. So there is an abnormal reflex clearance and frequent transient lower esophageal sphincter realizations, and so we can acknowledge these physiological reflex and pathological reflex in this GERD. This right-hand side is the functional component. Functional component is the reflex hypersensitivity and the functional heartburn. So number evaluation means endoscopy and the pH monitoring, 24-hour impedance manometry, and or Bayesian esophagogram, and other measures like radiography. So in the management portions, diet and lifestyle modifications, and endoscopic measure, mainstay of treatment is the PPI, and now PCAP, and the if they're not responding to acidicant refractory, we can do this endoscopic anti-reflux methods or surgical methods, and the surgery is the last resource for the cure of the GERD. But even after endoscopic treatment or surgical, that GERD can be a recurrence or become best. So GERD is a very difficult medical condition we encounter day-to-day practice, and thank you.
Zifam, caring for well-being.